A very, very warm welcome to all of you. Namaste. For those of you who are joining for the first time, the Global Indian Physicians COVID-19 Collaborative was established on 11th of April with the support of Dr. Suresh Reddy, President of API, Dr. Ramesh Mehta, President of GAPIO, Sunil Patel from CAPI, Dr. Arun Garg from SINS, from Anju in Australia, and colleagues across the globe. We had a lot of support from IMA. Could everyone please be on mute? Yeah, we can, Dr. Sudhir. And so we've grown, and the idea really was to get onto this platform 1.4 million physicians of Indian origin who practice across the globe, 400,000 outside India. We now have a presence in 45 countries. It is day 159 since the first COVID case was detected and reported. COVID-19 has spread to more than 200 countries and territories, and the latest count as of 60 minutes ago was 6.87 million cases, with sadly more than 398,000 deaths. In India, the tally is 235,000 plus, with 6,642 deaths. There's been an explosion of knowledge like we have never known before. In the 159 days, we've had 1931 papers, which is an average of 121 papers per day. And from India, we've had 853 papers. From HCQ to plasma therapy to remdesivir to low molecular weight heparin to tocilizumab to steroids to ivermectin, nitazoxanide, novel therapies, everything that we want to know about will be discussed today. And if there is one CME that has it all, it is this Global Indian Physicians Collaborative CME. So let's get cracking. And to set the ball rolling, we have my distinguished colleague, Dr. Sudhir Parekh. Dr. Sudhir Parekh, there seems to be a problem with his audio. Can you unmute Dr. Parekh? Yeah, Dr. Parekh, can you hear us?
No audio.
Okay, well, we're going to request you to please start. We can hear you, Sudhir bhai.
Okay.
So please go ahead. Sudhir
Hi, dear friends. Welcome to our COVID-19 webinar. COVID-19 is an unprecedented event we have never seen in our lifetime. The last pandemic this severe was almost 100 years ago with the Spanish flu. Because of the speed and spread of the infection, we are in a unique situation where we have a moving target. We are learning about the disease as we treat it and care for the many patients at the same time. There are so many unanswered questions. Why do some patients get so sick while some have no symptoms at all? Why do the sick one all present with the different symptoms? Now is the time for the innovation and the global medical community to unite as a heroes against a common threat. So many different medications are being studied throughout the world, from antiviral to anti-parasitic, malarial medication to anti-inflammatory agents. We are all desperate to awaiting for the vaccine. And as we know, there are 10 big trials are going on about the looking for a correct vaccine. Along with the pandemic, mental health problems have ensued as a result of the fear, anxiety, and economic implications. We need to move forward, and what will help us to do so is the effective vaccine and the medical treatment. So let's hear our expert panelists here today. Let's welcome them and hear about the medical treatment and the vaccination. Thank you. Welcome everyone.
Thank you, Sudhir bhai. Sudhir bhai is one of the pillars of GAPIO. He is the chairman of Parekh Worldwide Media ITV Gold Channel. He's a very well-known expert in allergy. He's been awarded the Padam Shri, the Pravasi Bharatiya Samman, the Ellis Island Medal of Honor, and the title. I request everyone to please be on mute. And he is currently the Secretary General of GAPIO. It gives me great pleasure to welcome my dear friend, Dr. Sudhakar. Sudhakar is an American board certified internist and a specialist with his fellowship and board certification in gastroenterology. He practices in Georgia, and Sudhakar will take over as president of API later on in this month. Over to you, Sudhakar, to take over for the next 3 talks, please.
Good morning, Anup, and welcome you all, and thank you again. My name is Anup Sudhakar Janalagada, income president for AAPI. Yeah, we all know that currently in globally 6.7 million people have been diagnosed with COVID. We are learning every day, day to day, and see what the experts are going to say today. The first speaker is Dr. Indrapal Chabra. He's an internist from New York. He's a clinical assistant professor of medicine, Hofstra North Shore, LIG School of Medicine in the United States. And Chabra is the president of the Lafayette Medical Associate Practices. He's the man can tell exactly what is COVID. He took care of more than 200 cases in his practice till today, probably more. And see what Dr. Chabra is going to say about the clinical presentation of COVID. Welcome, Chabra. Can you unmute, please? Dr. Chabra, unmute.
Yeah, I'm unmuted. Thank you.
5 minutes precisely, because this is a really tight program, and we have Sadhguru exactly at 9 p.m. So we have to finish well in time.
Sure. So thank you. I'll try to go through this. So these are a few cases that I have taken care of in my presentation at the hospital. So let me just start the slideshow. Can everybody see this? Okay, good. Thank you. So what I wanted to focus on is the vitals that we were looking at, especially the desaturation and then the blood pressure. In the labs, we were looking at the liver abnormalities, renal failure, and also the elevated D-dimer, CRP, and ferritin. If that was elevated, then the patient probably has COVID, even if the swab was negative. So this was the algorithm that was started off by our institution. It's a busy slide. I hope this can be shared later on. I will not go into the details. But some of the drugs that are mentioned here, you'll be hearing a lot more details about those drugs later on in today's speakers. So jumping right into the patients. My first patient was a very sick patient in the throes of Cytokine Storm, and I want to show you how interleukin blockers they can work. This is a 66-year-old gentleman. He's a retired pulmonologist of Indian origin, past history of hypertension, diabetes, chronic kidney disease. He had a nephrectomy done last year in November for a transitional cell carcinoma. He developed fever, and after 2 days, he was diagnosed with COVID. And of course, like any other Indian doctor, he took hydroxychloroquine and azithromycin at home before he came to the hospital. His dyspnea got worse, and that's how he ended up in the hospital. He was hypoxic, and on day 3, his saturation dropped to 65% while he was brushing his teeth in the hospital. I was able to procure him into the trial for sirolimus, which is an IL-6 blocker. Within 2 days, his hypoxia got better. And in 10 days, he was able to be discharged home, although he did need some oxygen when he went home. My second patient, this is a CAT scan, by the way. And if you look at the sides, you see the ground glass opacities that everybody talks about in radiology. The second patient, this is just to show that you have got to be careful with these drugs. These are very strong immunosuppressors, and opportunistic infections can occur. This was a dear patient of mine from my clinic, 63-year-old gentleman, again, an Indian gentleman, past history of coronary artery disease. He had a stent put in 2014. After that, he changed his life around, and he was a very energetic guy. Asthma, hypertension, developed dyspnea and cough. When he came to the hospital, his saturation was only 92% on the pulse ox. Within a few hours, his hypoxia got worse. He was started on hydroxychloroquine in the hospital. The next day, his condition kept on getting worse. I had started him on high-dose steroids, and I also started him on anakinra, which is an IL-1 blocker. He was intermittent prone positioning, proning as they call it. It did not get any better. I had to give him 1 dose of tocilizumab. That was our protocol. Within 7 days, he got intubated, was taken to the ICU. He developed shock. His blood pressure was very low, requiring very high dose of pressors, multiple pressors. Developed right-sided pneumothorax, and his blood cultures grew a bug called Granulocetola ediosus, which is a type of a streptococcus, close to streptococcus. He kept on getting worse, developed renal failure, went on to be on dialysis. After about 14 days, our institution was approved for the plasma trial. However, even after the plasma, he died within a few hours. And this is his X-ray that shows the pneumothorax on the right side. So this third patient, 58-year-old lady, past history of hypertension, came with cough and dyspnea. She had a fever, saturating only 90% on pulse ox, required non-rebreather oxygen at 10 liters per minute. And when she was admitted, intermittent prone positioning, that helped a little bit, not enough. And the third day, I was able to enroll her in the Remdesivir trial. In less than 24 hours, her condition got better. And in 5 days, she went home not requiring any oxygen at all. And this is the X-ray that shows the ground glass opacities in her. So in the end, what I want you to take away is keep a very high degree of suspicion. If you have a patient with unexplained fever, cough, any other symptoms, these patients get very sick very quickly. Cytokine storm, you have to be afraid of that. And how do you identify the patient is going into cytokine storm? By looking at the hypoxia, CRP, ferritin. And don't be in a rush to put them on a ventilator. That causes trouble, such as pneumothorax, pneumomediastinum. I've had patients who have developed severe subcutaneous emphysema. The whole top part of the body had emphysema in that skin. Renal failure is a very big problem, especially in diabetics. And last but not the least, coagulopathy. Make sure you check the D-dimer when the patient goes home. And in the end, I would like to say, please take care of yourself. Stay safe. Thank you.
Thank you, Dr. Chawla. It's a wonderful and very practical presentation. And I think we're going to hold the questions to the end of the discussion. And our next speaker is Dr. Indranil Chakravarti. Dr. Chakravarti is a consultant pulmonologist and director of medical education at St. George University Hospital, London, and senior lecturer at the postgraduate medical school, University of Hertfordshire. Dr. Chakravarti also a deputy postgraduate dean in North London for health education in England, and he awarded the President Medal by Royal College of Physicians, London in 2019 for promoting excellence and quality assurance of medical education. Indeed, it is very, very debatable topic of hydroxychloroquine prophylaxis therapy. Let's see what you're going to say. Dr. Chakravarti, please go ahead.
I need to unmute myself. Hello, everyone. Thank you very much for this opportunity to talk about something which is really changing almost every hour. I come from the same place that my previous speaker came from. So I'm a clinician first. I'm a pulmonologist. As you know, I work in the front line of patients. And like everyone here, I'm looking for something to do to help my patients. So I'm going to talk in the next 5 minutes just basically touch on chloroquine and hydroxychloroquine, mainly hydroxychloroquine in COVID-19, what we know now and what I would view as the practical aspects of this therapy. So let's go first to, so I'm going to talk about the mechanism of action. So we need to understand why chloroquine or hydroxychloroquine would be effective in this situation. And I'll just touch quickly on that. Then I'll touch on a few studies which show effectiveness of these treatments in COVID patients. Then I'm going to talk mostly about prophylaxis. So 4 immunoquinoline antimalarials have been around for a long time, both as antimalarials and as disease-modifying agents in connective tissue disorders, and it's most rheumatologists are very familiar with usage, and in my case as a pulmonologist, I've used the same. It has been included in clinical trials, and one of the bigger trials that are happening in UK at present has 4 arms, and 1 arm includes hydroxychloroquine. It has been used, we know, in prophylaxis for health workers in India and in South Korea, and has a significant controversy been around between the regulators, and I'm going to touch a little bit on that. It has been temporarily withdrawn and now being reintroduced, so the goalpost is changing for this drug almost daily. So how does it work? The first concept is that it's a chemical, it's a base, and once it gets into the cells, it increases the pH, both of the endosome and also in the lysosomes. And by increasing the pH, it interferes with the cellular receptors of SARS-CoV virus accessing the cells, and therefore blocks viral infection. This has been shown clearly in vitro studies. We also know that it inhibits the quinone reduction and therefore reduces the biosynthesis of a transmembrane protein, and therefore it prevents access to the cells by the virus. It can also reduce or inhibit cathepsins, which are important in leading to the cytokine response, and also it interferes with the virion assembly. So in vitro cells, there is good evidence that it would be effective. This is an excellent diagram which shows what I've just mentioned about that, and it's in the Journal of Antimicrobial Chemotherapy. I won't go into that at the moment, but if you're wanting to look at that, this is a good place to go. So we know that it decreases viral replication, viral infection, and can also reduce inflammatory markers of cytokine response. So therefore, it has a significant advantage. The advantage of hydroxychloroquine over chloroquine is in its reduced retinal deposition and therefore faster clearance and less retinopathy. Moving quickly on to, so FDA, as you know, although said there was no adequate medication at the early stage of this condition, approved the use of COVID-19 in hospital setting patients, and therefore it has been in use. In the UK, we also can use it within a trial setting. Why is there a worry about hydroxychloroquine, especially in combination with macrolides? It is particularly due to the cardiac risk, which comes from an increased QT prolongation, and that leads to ventricular fibrillation. We also know that this is quite a rare occurrence. It's overall, the incidence is about 3 per million, and it's also supposed to be double in women. In patients who have established coronary artery disease or hypokalemia or heart failure, it's particularly dangerous in those patients, but the risk is quite small if you look at overall risk. So where is the evidence that hydroxychloroquine works in COVID-19 situations? The first study from China, which looked at 62 patients who were given 5 days of 400 milligrams of hydroxychloroquine per day, demonstrated that there was improvement in fever and pneumonia, and only 2 patients had mild adverse reactions. Then we look at the Marseilles study, and if you look here, again, there's a combination of hydroxychloroquine plus azithromycin combined with hydroxychloroquine alone and compared with control arm. They looked at nasopharyngeal carriage by PCR testing, and it showed that in combination with azithromycin, there was a reduction down to 100% of the virus from the nasopharyngeal airways. Now, further on, the same group have looked at 1,000 patients, and they report a 92% virological cure in this group, and they only report a 5% people with a prolonged viral carriage. Now, prophylaxis, there's an interesting study published by the Indian Journal of Medical Research looking at 20,000 asymptomatic healthcare workers. And again, in a case control model using 350 cases, they showed that there was a significantly reduced risk of COVID-19 amongst healthcare workers who were given prophylaxis with hydroxychloroquine. And they also demonstrated a dose-response relationship. The next work was done in South Korea, which looked at one single exposure from a hospital social worker, and 211 contacts were given hydroxychloroquine prophylaxis, and no one developed COVID-19 in that group. Again, a very recent study looking at 800 cases of people with an exposure to 10 minutes or more of, within 6 feet of patients with COVID-19, where there were either no personal protection or very limited personal protection. They were all given 4 days of hydroxychloroquine, and they were followed up with PCR, and they were found to have 12 to 14% between the control group and the treatment group. So there was no real difference between the number of people who went on to have the disease. And 40% reported gastrointestinal symptoms in the people given hydroxychloroquine. And this is the NEJM paper. So at present, there's significant difference of opinion between the regulatory bodies. In Europe, there is very limitation in access to hydroxychloroquine, and outside of trials in the UK, we are not able to use it. President Trump has obviously a different view about that, and he feels that this is obviously a biggest game changer. But if we are looking at I must mention the Mandeep Mehra's paper in the Lancet, which showed, based on Surgisphere's data, 93,000 patients from 671 hospitals, and the biggest problem was the significant higher risk of mortality in the people treated with chloroquine and hydroxychloroquine. Now, this came at a time when the trials were in place, and majority of trials pulled out hydroxychloroquine from their arms, including in the UK. Now we know that this data may not be as accurate as it has been reported, and therefore we are revisiting or restarting involvement of hydroxychloroquine in this area. And this particular trial and retraction of the data has done huge damage to the credibility of hydroxychloroquine in this particular question. This is my last slide. So as a clinician, what is the question that I'm looking at? If there is a drug which is safe and inexpensive and can be given to lots and lots of people, and it reduces transmission and improves global health, then it's a fantastic solution. Is it permissible to take a controlled risk? And I'm talking here about the cardiac risk of using this. Yes, the risk is quite small. It's possible to do that. But then in terms of prophylaxis, are we in a position to say that safely patients with COVID-19 can be treated with this condition? I'm not sure we know the answer to that. Perhaps there are better drugs to use in this situation. And finally, am I going to use it for prophylaxis? I think post-exposure prophylaxis is justifiable in this situation, perhaps currently, but mass prophylaxis, probably we're not ready yet. The risks are too high. Thank you.
Thank you, Dr. Chakravarti. Outstanding presentation. I think again, we would like to hold the questions to end of the discussion, all the discussions. The next speaker is Dr. Madhavi Gorusu. Dr. Gorusu is a hematology oncologist at the University of Connecticut, United States, and works at the Starling Physician Hartford Hospital. He is currently serving as the president of Connecticut Association of Physicians of Indian Origin. I want to say one thing. In the early part of COVID in the United States, RP took a great initiative. And in fact, we promote the importance of plasma treatment, particularly sick patient, COVID patient. Madhavi, the main anchor for RP, took the task. Nobody can do any better job than Dr. Gorusu. Dr. Gorusu, please go ahead and present on plasma therapy.
Thank you so much. Thank you. That was such a warm introduction. Can you hear me, guys? Good. Again, a very good morning, good evening to all my esteemed colleagues from all over the globe. Wow, close to 500 participants. That is amazing. What a good job. So I have started my timer so that I will not go anything beyond the very valuable time. So like what Dr. Janalagada has mentioned, I think, and what Dr. Sibal has mentioned, we are never have been in this kind of learn on the go and doing as terrific job as we all can. So talking about one of the valuable tools to support our COVID-19 patients, both who are sick. Prophylaxis will go over a little bit. So then the question comes, we do not have any published data as much for the COVID-19 patients. And so based on what have we started this journey giving this treatment to our patients? And again, being a hematologist, oncologist, and probably like all in our specialties, the value of multidisciplinary care, I think this particular situation, how we all have rallied from different specialties to kind of give the best supportive and the treatment for our patients, because these antibiotics, these other the interleukin inhibitors, I think time alone has to tell us what each treatment modality has, how much of the weight in helping the patients. But having said that, so let's take a look at what the history has been in the role of convalescent plasma, i.e. the plasma from a recovered patient to help another sick patient. Is this totally new? Doesn't look like, because as I have put in my slides, couple of studies from 1932 to the most recent is that in the study published in JAMA in 1932, where the serum was given to the patient suffering from polio. And then came the study in 1935 for the measles patients. And then came in 2010 for the treatment for the influenza patients. And in 2016, not too long ago, was the immunotherapy for the Middle Eastern respiratory virus, the MERS virus. And the most recent in 2018 was the study for the Ebola virus part. So through all this, when in it was approximately end of March and early April that FDA has given the initiative for the EIND, the emergency indication to enroll patients for the plasma therapy part. So based on this data that passive immunotherapy helps patients recover in a quicker way, and also earlier the treatment that they were better. So as of yesterday, when I looked once again before I finalized my slides, I do not think there have been any established hundreds of patients enrolled studies to show the data of the plasma therapy. So I took it as an example of this particular study by Duan et al. And his colleagues, the study from the Wuhan, where this is a very small study, agreed, only like 10 patients, but it gives the gist of what my esteemed colleagues before me kind of went over what they're monitoring in the acutely ill patients. So I thought I'll just put this as a snapshot. Again, as you see at the one side of the screen is the improvement of the radiologic findings, the ground glass opacities in patients who have received the convalescent plasma therapy. This the median time between the COVID symptom onset and the plasma therapy was like 16 days. But I would like to mention that later when they analyzed, earlier the patients received the treatment, they were better off. And at the other side of the screen, you will see the different parameters that are being monitored, which is the C-reactive protein, the lymphocyte improvement, the saturation, the transaminase part. So looks like we are already crossing the time limit. So what is the donor registry? Looking for the donor eligibility is the diagnostic test with the nasopharyngeal swab or the positive serologic test for the antibodies. And the criteria should be the resolution of the symptoms of the donor at least 14 days before. And remember, a negative test for COVID-19 is not necessary. And this is a quick snapshot of how from a recovered patient, the plasma is collected, the serum is being given, remember, both to the prophylaxis as well as the acutely ill patients. The reason I have put this snapshot of different trials is that, remember, several trials are being done in different settings, from the emergency room to the outpatients to the children, and not only the acute sick. And I think in time alone, we'll be getting the results of these published studies, which will show the safety. I think so far the signals have been that it is not unsafe and probably a reasonably efficacious treatment to help in the symptom recovery part. Well, how much each component of the treatment modality had a role to play in the improvement, once we have the published studies, we'll know. Thank you so much.
Dr. Sibel.
Weeks to complete. So Gilead is trying to overcome that by providing voluntary licensing for mass production to 5 different companies in India and Pakistan. And hopefully we should be able to meet the supply and demand over time. So the compassionate use program was published in NEJM on April 10th. It is sponsored by Gilead, uncontrolled open label program without a predetermined number of patient sites or duration. There are specific inclusion criteria listed, as you can see from here, and the data was evaluated on this cohort, which include clinical status assessment by 6 points ordinal scale mentioned here, status from discharge to the 0.6 of this death, and this was ordinal scale used in pretty much all the studies. Mortality was also assessed, as well as adverse events. So in this, basically, I wanted to put all data together, mentioning here that there was out of all these 61 patients enrolled, 53 patient data was reported at median days of 18 days. You can see that invasive group, about 34 patients were included in that, of which 19 patients has significant improvement. Overall, 68% people improved. 7 out of the 53 people data was reported. That is 13% people died. 6 of them belong in the invasive group, which included intubation as well as ECMO. And the ambient air or low flow oxygen or non-invasive methods or high flow oxygen, this was about, they tend to improve better. The mortality was more in people who were older than 70 years or had comorbid conditions. You can see the further data in NEJM. Second simple study was published. This was on to assess the Part A and Part B program. Part A was involved about 400 patients and 197 in longer trial of remdesivir, 10 days, and 200 patients were involved in the 5 days trial. Again, inclusion and exclusion criteria as mentioned. And in this, the primary endpoint was assessed by 7-point ordinal scale in 14 days. And it showed that the efficacy and safety eventually, there was no significant difference between 5 days course or 10-day course of remdesivir for severe COVID pneumonia, not requiring mechanical ventilation in baseline, no difference. Baseline characteristics were similar in both the groups, except that in the 10-day group, there were higher proportion of patients who had hypertension or severe disease categories. In safety-wise, there was transient elevation of liver enzymes were observed in patients with 2.5% in 5-day and 3.6% in 10-day group respectively. Patient also experienced greater grade 3 elevation in creatinine and decline in creatinine clearance in 10-day group. Overall, 5-day remdesivir course was not significantly different in efficacy versus 10-day course for severe COVID pneumonia who are not on mechanical ventilation at baseline. But the 10-day course could be more beneficial in patients who progress to mechanical ventilation. I just want to highlight a few of the studies which is coming up. The Chinese study was published in May 16th in Lancet, which was with remdesivir versus placebo, was closed early, underpowered, and no change in clinical outcome was found. I also talked about the Act 1, Act 2 trial. Further trials are coming up, which is Solidarity Discovery, which includes remdesivir with other components. And I'm way past my time. I'm so sorry. Thank you so much, and keep safe.
Yeah, thank you, Dr. Sanjay Agarwal, for this amazing talk. I would like to introduce Dr. Senthur Nambi. Dr. Nambi is an infectious disease specialist at Apollo Hospital, Chennai, India. Dr. Nambi was previously an assistant professor of medicine at Chettinad Medical College, Padur, India. Dr. Nambi has published many research papers to his credit. Dear fellow physicians, please join me to invite Dr. Nambi to speak on antiretrovirals and low molecular weight heparin. Dr. Nambi.
Thanks, Dr. Sibal, for the opportunity, and I will just be sure. Thanks, Dr. Sibal, for the opportunity, and thanks, Dr. Suresh Reddy, for the introduction. And this is a cartoon that most of the physicians managing COVID should be familiar with. And with antiretrovirals, the site of action is RNA translation, and that is the conversion of polypeptides to the non-structural proteins. It acts as the protease enzyme. Going on to the lopinavir ritonavir, the other antiretrovirals that has been studied is darunavir and atazanavir. Unfortunately, not much data for it, so I would just focus only on lopinavir ritonavir. As I said earlier, it acts on the protease enzyme, the RNA translation process, and there is no in vitro studies for SARS-CoV-2. But this molecule has been earlier studied for SARS-CoV-1 and MERS-CoV with some limited success. With respect to the real world data, with respect to COVID, and we have this publication, a randomized controlled trial of around 200 patients on lopinavir ritonavir. What they found was when they compared that with the control arm, it did not make much of a difference. But one criticism against this study was most patients with lopinavir ritonavir were started much later in the course of the disease. The median duration when lopinavir ritonavir was started was around 13 days. This is another study from Hong Kong, which again looked into lopinavir ritonavir versus a triple drug combination of lopinavir ritonavir plus ribavirin and interferon. But let me reiterate, yes, this triple drug combination had some effect, but this is not a clinical study, because that is what I would presume. Why I'm saying that is, this looked into virological clearance. What they were trying to look was the clearance of the virus by RT-PCR. But did it have any clinical correlation? Most of us do not know. Why I'm saying that is, why it did not replicate a real life scenario is because very few patients required oxygen in this study. And as far as I know, there is only one patient on ventilator. And so that is the data with respect to this study from Hong Kong. So my thoughts on antiretrovirals or lopinavir ritonavir is no clear benefit with the present data. Could be a treatment option if initiated early. Probably we need to wait for the WHO Solidarity trial if there is any positive news for lopinavir ritonavir from it. Going on to low molecular weight heparin, COVID is new, so would be this terminology called COVID-associated hemostatic abnormality, CAHA. And infections do cause DIC, but with COVID it's slightly different. The thrombocytopenia is at best moderate, fibrinogen levels tend to be higher, D-dimer levels tend to be much higher. The prolongation of PTA, PTT tends to be modest. The prothrombotic state generally predominates, and that is a big learning for clinicians like us. And this is something that we would do routinely in patients with COVID who gets admitted into the hospital. Look into the D-dimer, because the D-dimer levels at the admission definitely predicts the in-hospital mortality. Anything more than 2 is not a good news as far as patients are concerned. And what does it mean being a prothrombotic state is we find all forms of pulmonary embolism. Let it be a segmental pulmonary embolism, subsegmental pulmonary embolism, lobar, or a central PE. In addition to it, we could have deep venous thrombosis, which could be either proximal or distal. So COVID is a definite prothrombotic state. So what do we do with that? There is definite mortality benefit in patients whom were put on prophylactic heparin. Prolonged APTT is not a contraindication to anticoagulation. In this subset, start prophylactic low molecular weight heparin immediately in all admitted patients, unless they have any bleeding or a low platelet. Anyone admitted to the wards, you would look into once daily dosing. Someone who in the ICU, you would look into minimum of twice daily dosing of low molecular weight heparin. So how would we manage these patients with coagulopathy? You would have to do the basic test. That will be the D-dimer, prothrombin time, platelet counts, at least once in 2 days. And how would we manage? Where do we place the low molecular weight heparin? So for all patients getting hospitalized, in the ward, it's going to be once daily. In the ICU, it's going to be at least twice daily. In addition to it, in anyone who has a rapid respiratory deterioration requiring intubation, ventilation, or change in baseline from their oxygenation status with high D-dimer, you would always think of venous thromboembolism. So if we could prove it by either an ultrasound of the venous system or a CT angiography, it's fine. But for whatever reasons, the diagnostic testing is not possible, if there is no bleeding risk, then we should consider therapeutic anticoagulation in patients who have a rapid clinical deterioration plus high D-dimer. So to summarize how would we place the low molecular weight heparin, in outpatient, generally not a role, but still you would consider in obese patients who are not going to be ambulant after discharge. A pregnant individual, definitely it's a strong consideration. Someone who has already been on molecular weight heparin for some other reasons. So in that situation, an outpatient low molecular weight heparin may have a role. Otherwise, you would do those coagulation tests, D-dimer, prothrombin time, platelet counts. Any patient in the ward, you would do a standard prophylaxis, whereas anyone in the ICU or with ARDS, you would do an escalated venous thromboembolism prophylaxis. Someone with a confirmed venous thromboembolism or a presumed PE, you would go for a therapeutic dose anticoagulation. And with that, I end my lecture. Thank you.
Thank you, Dr. Nambi, and for the amazing talk. And I have a personal invitation of my own. I would like to personally invite you all, the speakers and the audience, to join the first virtual summit organized by API in collaboration with GAPIO and BAPIO from June 18th to June 28th. That's closing in on COVID. That is the title. And thank you, Dr. Nambi, for the very informative talk. Now I would like to introduce Dr. Babu Abraham. Dr. Abraham was trained in pulmonary medicine in United Kingdom and underwent a fellowship training in critical care medicine at the University of Toronto. Dr. Abraham is a senior consultant in pulmonary and critical care medicine at Apollo Hospital, Chennai, India. Dr. Abraham is an examiner for Diplomat of National Board in Critical Care Medicine conducted by the National Board of Examiners. Dear friends, please join me to invite Dr. Abraham to speak on tocilizumab and steroids. Dr. Abraham.
Dr. Reddy, I'm not able to get a login. Can you hear me?
Yeah, you can do the audio. Please go ahead and do the audio.
Sorry, I'm not able to.
We are able to hear you.
Okay, I'm not. I don't think I'll be able to share my screen.
Anupam, should we just go with the audio, or we'll get a different speaker? Not able to hear you, Anupam.
You're muted, Anupam.
You are calling. Babu, you could just go on and read out from your slides and make a oral presentation. Seasoned speaker that you are, I'm sure you.
I can do that, but I will not be able to share the slide.
No problem.
Yeah, please go ahead, Dr. Abraham.
Okay, I'm sorry about that. I did not know what happened. Okay, now steroid and tocilizumab are the two immunosuppressants which we are trying to use in COVID. Now, if you look at where we want to use these immunosuppressants in any infection, it's time when the viremia has settled and the inflammatory process is starting. When the inflammatory process starts, that's when the lungs get affected. So we are planning to use this medications at the time when you start seeing hypoxia setting in. So most of the time, the decision is not whether we should use, it is when to use it and at what dose to use it. So looking at the evidence, there's very clear evidence that there is no much benefit from using steroids in a corona infection. That's seen from the SARS-1 in 2003. there was actually no benefit. Then in MERS, again, no benefit. Even in influenza, when you look at it, it was in fact increased mortality when you use steroids. So I do not know why we continue to have our fetish with steroids in viral pneumonia. Now, the recent COVID-2 infection, the corticosteroids use, the first systemic review which looked at it had 4 studies, out of which all were retrospective observational studies. 2 were negative, showed that steroids could do harm. 1 did not have any benefit. And 1 study alone showed that if used in a very severe pneumonia, could reduce mortality. Now, recently, there is a study which has come out of Detroit, which looked at using short course of steroid very early in the disease. And that is a sort of quasi-experimental pre and post out of study, which showing some promising results. It showed that when you use steroids in a dose of methylprednisolone equivalent of 0.5 to 1 milligram per kilo for 3 days, it reduced death, reduced respiratory failure, and reduced escalation of disease. So there was a composite outcome improvement, and each of these primary outcomes like death, respiratory failure, and disease worsenings improved, and the number needed to treat was 8. So this is one of the first studies which is showing some promise, and we need more randomized control study to say whether steroids will actually work. Coming to tocilizumab. Tocilizumab is an IL-6 antagonist used well in rheumatology, and showing a very good effect in rheumatology. And in ICU, we have seen that whenever we extrapolate therapy, we always burn our fingers. And this is what exactly we are doing. We are using tocilizumab, which is shown to be a very good IL-6 antagonist, and is being used in COVID just because most of the COVID patients who are sick has raised IL-6. And the studies looking at tocilizumab in COVID-19, there is 1 random systemic review, which has again 6 studies, 2 of which were observational retrospective analysis, and 4 were just case reports. Those were very poor studies from which we can make no conclusion. Recently, there is another study again coming out of Michigan, which has looked at using tocilizumab in an observational control study, and that study is again showing some promise. It has shown a decreased mortality when tocilizumab is used in sick patients who are on ventilator with respiratory failure at a dose of 8 milligram per kilo as a single dose. Again, remember that this is an uncontrolled observational study, so we will need randomized control studies to tell us whether we are going to use, whether we can use tocilizumab or not. Thank you.
Thank you so much, Babu. Despite the glitch, I think you made a fantastic presentation and the message was loud and clear. So deeply appreciate this. We move on to our next set of talks, and to introduce the next 3 speakers, I have the privilege and honor of introducing our respected colleague, Dr. Nandkumar Jairam. Dr. Nandkumar Jairam is a well-known surgeon. He is also the CEO and Group Medical Director of Columbia Asia Group of Hospitals, and is the Vice President of CAPIO. Over to you, Dr. Nandkumar.
Thank you, Anupam. It is my pleasant duty to introduce Dr. Sunita Naredi, who is an ID specialist in Apollo Hospital, certified by the American Board of Internal Medicine in Infectious Diseases. And her expertise includes nosocomial infections, immunocompromised hosts, HIV, complicated infections like fungal infections, MDR tuberculosis, H1N1, and travel medicine. Let's hear Dr. Naredi.
Thank you for the invitation. Today I'm going to be talking primarily about using repurposed drugs for COVID, the ones that don't have anyone to back up. Most of these are in principle, so we'll need to do a lot of research for a lot of these things. So let's move on. Starting with ivermectin. We have heard a little bit of ivermectin, and to understand what ivermectin is and how it works. Ivermectin is a drug that has been, we all know, is it's antiparasitic, but it also has antibacterial, anti-cancer, and antiviral properties. It has shown some activity against a bunch of different viruses, including Zika, West Nile, chikungunya, dengue, and so on. But how does it work in coronaviruses? What we do know that happens in coronaviruses is the virus typically binds to the imp alpha and beta 1 proteins and thereby enters into the nucleus of the cell and replicates. Ivermectin basically prevents the binding of the virus to the receptors, and thereby entry into the cell wall, into the cell is restricted. So this is the principle with which it works. And thereafter, what else do we know? There have been in vitro studies using ivermectin on the SARS-CoV-2. And if you see this pictorial here, the virus has significantly decreased on exposure to the ivermectin. Now you have to remember here that this is an in vitro study, and the dosage that they have used of ivermectin is not achievable in most therapeutic dosages. So does it work? It probably works. Can we use it in real time? We still don't know at this point. We have to wait for more research to come out. What about other drugs? Nitazoxanide. Now, nitazoxanide is basically an antiparasitic and antiviral prodrug. It potentiates interferon alpha and interferon beta production. It has previously shown to have some in vitro activity against MERS-CoV and other coronaviruses. In principle, nitazoxanide, when given at 600 mg twice a day for 5 days, had shown to have some reduction of symptoms in influenza infection as well. In terms of use in, again, COVID, the therapeutic trials are ongoing. Moving on to NAC, we all use this a lot for multiple different purposes, including chronic respiratory diseases, paracetamol overdose, acute bronchopulmonary disease, and so on. At higher doses, though, which is about 1,200 milligrams, it has antioxidant properties through complex mechanisms, and that can combat conditions of oxidative stress. It has been used in combination with conventional treatment for community-acquired pneumonia, where it showed that there's improved oxidative stress and inflammatory response. NAC inhibits inflammatory markers like IL-8, IL-6, tumor necrosis factor, and so on, in diseases like influenza and respiratory syncytial virus as well. So there is a potential role of NAC at a higher dose, that's 1,200 milligrams per day in COVID-19 as well, that potentially can help in cytokine storm syndrome and ARDS. Again, this is another principle that needs to be worked on. Moving on to tetracyclines. Now, tetracyclines are basically lipophilic antibiotics that are known to chelate zinc compounds on MMPs. Now, coronavirus relies heavily on MMPs for survival, cell infiltration, and cell addition, replication, and many of which have zinc as part of their MMP complex. Tetracycline also has zinc chelating properties, and this can potentially aid in inhibiting COVID-19 infections in humans, and thereby limits their ability to replicate within the host. And tetracycline may also be able to inhibit RNA replication on positive sense single-stranded RNA like the COVID-19. It has anti-inflammatory properties as well. So moving on to doxycycline in specific, it's a second-generation tetracycline with broad-spectrum antimicrobial, including antiviral properties, and we all know that it also has anti-inflammatory properties. In vitro, it has shown some activity against other viruses, including dengue, chikungunya, and so on. So there is a potential role of using doxycycline along with chloroquine, maybe as a prophylaxis. Again, all of this is in principle. We need to do more research on this. To summarize, tetracyclines can be potential therapeutic agents for COVID, and they are relatively safe agents, and that can be considered as optional drugs. Again, investigation is required to see how this would work. This is an interesting article that came on Pidotamid. There are a few articles that came out primarily from China. This is what is Pidotamid? Pidotamod is an immunomodulator, and it reduces acute exacerbation of respiratory tract infection in pediatrics. Pidotamid dispersible tablets were used occasionally in the treatment of 2 patients with suspected coronavirus pneumonia. And let me explain to you how this actually happened. And they say that they had a curative effect. But if you actually look into this particular family had an uncle who was pneumonia. And they learned, after the uncle visited them and left, they learned that the uncle turned positive for COVID. And then the uncle left and they found that he was positive. The next family went into isolation. Now, the patient 1 in this family who developed symptoms first. Initially, he took some Chinese medicine, and that did not make any difference. And symptoms continued to worsen. It included being febrile, chest tightness, cough, and dyspnea. And he happened to have this pidotamide tablets with him at that point in time. And so he chose to take this medication, and the symptoms resolved in 20 to 30 minutes. Subsequently, his wife also developed symptoms, and but the wife was taken into the hospital, and so she did not get the same medication. Then the mother-in-law developed symptoms, and he gave the same medicine to the mother-in-law as well, and she also symptoms resolved for mother-in-law. But the interesting thing is both of them tested negative for RT-PCR subsequently. The first patient, though, had changes consistent with COVID on the CT. If you look at the antibody production, the first patient did not even produce antibodies, but the mother-in-law did produce antibodies, as you can see here. The wife who tested positive for COVID also did not produce antibodies. So these are all anecdotal reports. You can't make any decision based on this information, but this is an interesting anecdotal information. So to summarize, repurposed drugs are good options. Research is required. Unfortunately, there's no backing for these drugs by major companies, so it's left to their own trials. So we'll have to see where we go for, but some of these may be good options.
Thank you, Sunita, for exposing to us some of the other options and possibilities of antibiotics in COVID. I'm sure that only time will tell us how good or effective these are. It is now my pleasant duty to introduce Dr. Sainath Haranath, who is a pulmonologist and critical care specialist working at Hyderabad in Apollo Hospitals as a senior consultant. He's an American board-certified internal medicine, pulmonary medicine, and critical care, and the medical director of E-Access Tele-ICU services. He's going to talk to us on more novel ideas, plasmapheresis, HPO, transfusion. Dr. Haranath.
Hi, this is Dr. Sai. Thank you, Dr. Jairam Nandakumar, for introducing me, and thank you, Dr. Sibal, for this wonderful opportunity to share our information. Just a quick check, audio is okay? Great. So I'm just going to quickly touch on novel ideas. I know we have all fairly run out of options. We've looked at all the drugs, and looking at everything so far, we may be left with only 1 or 2 options. It's like we're flying in a plane and the pilots come back and said, guys, any ideas? So when we look at the novel concept, the plasmapheresis, bloodletting, or giving a transfusion, blood giving, or perhaps just using high pressure oxygen, are these the options that are available? Now, if you're in Australia, you're probably ready to sleep. So if you can look at this slide, go hit the bed right after this. Plasmapheresis is removal of large molecules or cells from the plasma. There are multiple complications. HPO, or hyperbaric oxygen therapy, is using a high pressure chamber to increase the oxygenation. And blood transfusion is not something we should be doing. There is no transfusion related transmission. So people who have actually received blood have not shown any signs of coronavirus infection. And there is a possibility that donors who are giving blood have asymptomatic infection, but the probability in the test that they've done has been slow and low. So the next concept we will want to talk about really is about plasmapheresis, where several studies have come out of China. All these are, of course, case series where they've done plasma exchange and they've shown some results. The concept is that you're taking out the viral particles and replacing it with volume. Now, Turkey used it very successfully in a very specific instance of autoimmune meningoencephalitis in COVID-19. They showed an improvement in mental status. They also showed that the ferritin levels dropped. There is a nice editorial by Keith in a recent article where he talks about an argument for therapeutic plasma exchange. They have been dealing with the concept of immunostimulation and immunoparalysis. In sepsis and other syndromes, we know that there is an initial revving up of the immune system to fight the infection, and then there is a suppression. And they feel that maybe working on plasma exchange may be modulating that phenomenon. The controversy, though, is that sometimes what happens is that you're going to remove useful chemicals also. There is a study that was done with the H1N1 influenza virus in 2009 in children. That is where the concept came in, that it showed that there was an improvement in outcomes and patients were able to actually improve their oxygenation and their respiratory failure reversed after using plasma exchange. There's multiple studies in clinicaltrials.gov which are looking at this. There's an Egyptian study looking at methylene blue along with plasma exchange. There's a Spanish study recruiting for a RCT for plasma exchange. And a US study is planned along with the drug called ruxolitinib to work on plasmapheresis. The concept also is of using lectin affinity plasmapheresis for the MERS virus and the Marburg virus. They've shown that theoretically you could actually remove the virus using the binding of the virus to the lectin particles. And again, these are theoretical, and for the coronavirus, we really don't know. But the idea seems to be fairly reasonable because you have an option to change the composition of the blood relatively quickly and perhaps decrease the viral load. There's also the concept that you may decrease the amount of inflammatory work that the body has to do if you remove the bolus of the viruses that are present in the system. Moving on to hyperbaric oxygen therapy, essentially the normal atmospheric pressure, as you know, is 760 millimeters of mercury. The oxygen dissolved in the blood is very minuscule. If you can actually increase the pressure, you can push more oxygen into the dissolved oxygen. And in a slide or two, I will show you what the concept is all about. What they've shown in a Chinese series is that they were able to prevent intubation in certain patients, and they actually managed to get them off with BiPAP also. There are 7 trials right now registered for this. The earliest one is already ongoing in Israel, and that ends in a few days, actually in June 30th. And the theory is that you improve tissue oxygenation and improve the anti-inflammatory process. The Israeli study is using 2.2 times the atmospheric pressure, 60 minutes twice a day for 4 days. And they're measuring cytokines. Of all the studies going on, this one seems the most detailed. The Swedish Institute, Karolinska Institute, is also studying 200 participants. However, this RCT will not complete until the end of December 2021 or 22. So it looks like most of these people are doing a proper research in order to get a good outcome, and they're extending it out, assuming that the corona epidemic is not going to end very soon. The next concept we want to talk about is blood transfusions. There are some case reports talking about giving blood to improve oxygenation. This is a disproven theory for several years, perhaps over a decade now, where blood is not helpful for oxygenation except in extreme cases of extremely low anemia. But there have actually been people surviving with a hemoglobin less than 1 without getting blood transfusion as long as there's a volume expansion. This is a physiology concept which talks about the relationship between oxygenation and oxygen saturation. The concept begins there, saying that if you can actually increase the hemoglobin, perhaps you can increase oxygenation. It is an unproven experimental phenomenon which we should not be indulging on. We should encourage blood donation, however, because it is still safe, and people are actually, in the last 3 months, blood donation has decreased, and that is a problem because we are going to need blood for other problems to be sorted. This is the final slide here, which talks about the rate of oxygen delivery is dependent on the cardiac output, depends on your hemoglobin level, depends on your oxygen saturation, and also depends on your dissolved oxygen. So this talk today has been talking about hyperbaric oxygen, where you're actually working on the dissolved oxygen, and it's a very minute component, but if you're teetering on the edge of oxygenation, you may benefit from a little bit of a boost. And I think there is some hope for this. In India, there are a few centers. The second concept is hemoglobin. The theory is that if you increase hemoglobin, it might work. But in practice, there are more side effects of hemoglobin because you're going to end up with volume-related acute lung injury, and I would not recommend that. And of course, the cardiac output is important. So in conclusion, I think of all the 3 novel therapies, I believe hyperbaric oxygen may be of benefit, and plasma exchange may be something to look forward to. There are several HVO centers around the world. In India, there is a hyperbaric medicine organization. I think Apollo Delhi also has a center, and any place where there's a Navy institute will have a hyperbaric center. The practical difficulty of putting patients in and out is a whole another story. Plasmapheresis is widely available, and I believe the take-home messages continue to encourage blood donation, and let's keep our fingers crossed. Thank you very much again for this opportunity.
Thank you, Dr. Harnath. Over to you, Anupam.
Thank you so much, Sai and Dr. Nandkumar. And we now move on to the next set of talks. And to introduce the speakers, it's a privilege to introduce Dr. Arun Garg. He's a well-known biochemist working in Vancouver. He's the medical director of the South Asian Health Institute, and he's an adjunct professor at Fraser Health Sciences. He's a member of the executive committee of GAPIO. So over to you, Dr. Arun Garg.
Thank you, Anupam. It's a great privilege to welcome you all. Greetings from beautiful British Columbia. I have the privilege of introducing Dr. Randeep Gularia. Dr. Gularia is Padam Shri Randeep Gularia, reputed pulmonologist and well-known figure in healthcare. He will be talking about containment strategies for India. Dr. Gularia is currently director of All India Institute of Medical Sciences, New Delhi. Dr. Gularia is part of core team of top Indian officials reviewing and monitoring pandemic in the country and is involved in building strategies for prevention, containment, and management of COVID-19. Please welcome Dr. Gularia.
Thank you very much. I hope you can all hear me. I don't have any slides to prepare because we're in the thick of a pandemic, and even in our hospital at the All India Institute of Medical Sciences, currently we have more than 800 patients admitted who are COVID positive, and many of them are quite sick on ventilator. And as you know, the number of cases in India, especially in cities like Delhi and Mumbai, has really increased a lot. But I'll be talking briefly, and I'll just mention what we've been doing as far as containment strategy for COVID-19 is concerned. Now, to begin with, it's something that one was prepared and was not prepared as far as the pandemic is concerned. I remember that even almost 15 years ago, there was a lot of concern that we should have some preparation for a pandemic. This was basically when we had the SARS outbreak and when we had the H5N1, which is also known as avian influenza. H5N1, as you know, also causes very severe ARDS and has a case fatality of more than 60%. Luckily, that virus did not mutate to become a pandemic virus, but that really caused a big scare as far as India and Southeast Asia was concerned. And that led to the government of India forming what is known as a joint monitoring group for outbreak, which was chaired by the Director General Health Services to keep really have a regular meeting or to see what they could do for any outbreak. And this evolved into looking at the H1N1 outbreak, the MERS outbreak, the Ebola outbreak that we had, and of course now as far as the pandemic is concerned. So when we had the outbreak of COVID-19, the group and the ministry very quickly actually instigated initial monitoring of all international flights which were coming, and the screening was started way back in late January. Subsequently, as the number of cases increased, it was recommended that we should have an early lockdown, and when the cases were not that many, India instituted a lockdown strategy which was across the country. This strategy we had hoped would actually also help in decreasing the number of cases or bringing it down, but that did not work as successfully as we would hope to. And this is basically because of the fact that we are a democracy, and it's not that you can enforce lockdown as aggressively as you would have liked to. And secondly, there were a lot of unexpected events which happened despite the lockdown. But it really gave us opportunity as far as containment strategy was concerned to work and do things, because the cases, the rise in cases was not as much as one had worried about or feared, and we were able to flatten the curve to some extent. What we were able to do was build new labs as far as diagnosis and testing is concerned, because that was something which was of utmost importance. And when we started off, we had what was known as the VDRL, the Viral Diagnostic and Research Laboratories of the ICMR, and we were doing only around 10 to 20,000 tests a day. This was also, these labs were made when we were looking at H1N1. From 10 to 20,000 tests a day, yesterday we did more than 1,37,000 tests per day. And this capacity we are hoping to double by the end of this month. So the number of tests that we have started doing has really been ramped up. All medical colleges, all CSR, DBT, DST labs have now been enrolled and trained for testing. Even veterinary labs and the other agriculture universities have also come on board to really increase India's capacity for testing. Along with that, we also realized that we will have to increase our hospital capacity. And as you've been hearing during the talks, we don't have some definite specific therapy. A lot of treatment strategies have been tried all over the world. But one thing that we realized that we would really need for our sick patients is having adequate oxygen supply even at a district level. And over the last few weeks, this has been a major push that we have what we call COVID care centers, COVID hospitals, and COVID ICUs. And both the COVID hospitals and ICUs have to have full beds with oxygen facilities even at a district level. And a lot of work was done in making sure that this is done, including having ventilatory points. A training facility was also started, and a lot of webinars were done for doctors and nurses and for infection control practices also, because healthcare workers need to be protected as much as possible. We also started a Connect facility at the All India Institute of Medical Sciences, where we were having our pulmonologists, critical care specialists, ID specialists who were working with doctors at the district hospital who could really advise them on management of these patients. Because this is a complicated disease which has systemic involvement, and management requires a multi-speciality approach. So a lot of activities were done. A research group was also set up by the ICMR, and we have now a large number of research projects. You saw the presentation of this study published in the Indian Journal of Medical Research on hydroxychloroquine as prophylactic therapy. There is an ongoing trial on BCG vaccination in the elderly. We are also looking at Ivermectin, part of the Solidarity trial. And ICMR has just completed a large serosurveillance study in all the districts of the country to see in the hot spots and the cold spots, what is the antibody titers in our population and how much is there, how much of asymptomatic or mildly symptomatic cases have been there who have recovered without any treatment. There are big challenges that we still face. We have ramped up our production capacity, but there is still a lot of work that we need to do. And the challenges are more and more because of the population of the country, the social and economic divide that we see in both rural and urban areas, and the hotspots that we have in main cities like Delhi, Mumbai, Ahmedabad, Indore, where there is a huge number of cases happening because of the simple fact that there is a crowding of people, there is a lot of clustering without much degree of social distancing. So there is ongoing many containment strategies which are working. There has to be micro planning at a city level, at a rural India level, and at a national level. So a lot of work is being done. The Prime Minister's office has formed what is known as empowered groups. There are almost 10 empowered groups which are looking at different areas of how one can contain the pandemic, and there are various strategies which are being worked at. So this is just to give you a broad overview of what we're doing. I would be happy to take any questions and suggestions if that is needed.
Thank you, Dr. Gularia, for an excellent summary. Now, our next speaker, we're moving to Australia. And I'd like to welcome Dr. Jayanti Kathy Rayson from Australia. She'll be talking about lessons from Australia. Dr. Kathy Rayson holds dual fellowship in radiation oncology and palliative medicine and is working in Sydney, Australia. She is a clinical lead for COVID supportive care in Australia, largest cluster of COVID-19 deaths. Dr. Kathy Rayson, please do your presentation.
Thank you. I'm just trying to share my, Sorry, I'm just trying to share my presentation. Hang on a sec. Good morning, everyone. A very warm welcome and a huge thank you for this opportunity. Here I am briefly going to discuss with you the role of supportive care and palliative care and walk you through the journey of supportive care in Sydney during the COVID-19 pandemic. Well, it all started here in early to mid-March, and as we gathered the experience from Europe, we quickly realized it's very crucial to start planning, as there would be a huge surge in the demand for supportive care given that we have a large population of elderly people here. We needed to be proactive and we needed to be comprehensive in our preparation. We identified 4 key areas where we needed the preparation: staff, space, and system. Coming to the staff, we need to ensure that we have equipments and supplies to provide palliative care to a large number of people at a given point in time. This includes making sure we have adequate supply of end-of-life medications which are used for symptom control. And we also needed to come up with some innovative ideas for equipments which used to deliver the subcutaneous infusions. Usually we use Nicky pumps, other syringe drivers, but because of the infection control risk, we had to get quite a few numbers of surfaces which are disposables. We also needed to have some novel ideas about our consultations. As again, because of infection control, we need to change the way we practice. So we started doing quite a bit of telehealth. Coming to the staff, we need to identify key clinicians and who are experienced in palliative care, which includes doctors and nurse expertise. As the COVID preparation is going on, we also needed to go ahead with our normal day-to-day activities. So we divided our team into COVID and non-COVID team and to avoid cross-contamination as well. Quite a bit of time has been spent on educating our frontline staff about managing the symptom control, end-of-life care and equipments, as we thought that health system will be overwhelmed with people who are dying. We also had anticipatory medications which are embedded in our, called power packs, embedded in our electronic medical records. Coming to the spaces, we identified very specific wards with clear focus on comfort and dignity where people can die peacefully surrounded by their family. We also make sure if someone wants to die at home or the place of the choice of death, which includes aged care facilities, we make sure things are put in place. Coming to the system, healthcare pathways were created to triage and to identify patients who have complex symptom issues early on. COVID-19 supportive care hotline has been started with a 24-hour support with a single point of call. We also understood at this point in time, it's important we need to work as a team along with general practitioners, emergency physicians, ICU doctors, and geriatricians and other palliative care physicians. Well, we are kind of very well prepared for the worst, but fortunately we didn't get a surge in the demand for hospitalization. Having said this, unfortunately, we had the largest cluster of death, which is almost 20% of the country's death in the local aged care facility. So the aged care facilities here are non-government organizations with some federal funding. On Easter Sunday, we were notified that one particular staff member was tested positive and all other residents were isolated and other workers were tested, and the aged care facility went on a lockdown. Within a very short period of time, more than 70 people were infected, which includes staff and residents. So now we have a special task force which was set up, which includes general practitioners, geriatricians, infectious disease specialists, palliative care, public health, Ministry of Health, ambulance, etc. I guess the first thing we did was updating the advanced care planning with the clear goals and clear goals of care. We did discuss with general practitioners, residents, and the family, and coming up with treatment plans aligning with their wishes. I have to say almost 98% of the residents clearly said they wanted to stay in the nursing home, whatever happens. They were already elderly, frail, and with multiple significant comorbidities. We provided comprehensive supportive care, doing daily multidisciplinary meetings with general practitioners, physiotherapists, and other clinicians using telehealth model. There's 24 hours on-call support for palliative care and supportive care. Coming to the symptoms and trajectories, around 51% of the residents who were tested positive passed away, unfortunately. I guess our experience is very different from what we heard from other countries. Most of them were very peaceful. They were afebrile, mildly tachypneic or dyspneic. They rapidly deteriorated and passed away very peacefully. 49% of the residents recovered with significant fatigue, and they were deconditioned because of isolation and depressed too. There were things put in place to help with their recovery, including supplements, regular exercise, and sunshine therapy. I just have to say the significant psychosocial distress from the families and residents were extraordinary. They felt quite isolated and abandoned. Families were, so we just needed to do something about that. So most of the residents in the nursing home were given a smartphone so that they can speak to their loved ones and use the video calls whenever needed. Families also joined us mostly on telehealth to say their final goodbyes and prayers, and it was quite emotional. We did have face-to-face consultations at times so that the families can come in person, just one person at a time for 15 to 20 minutes with full PPE. They did have choice of window visitations as well. I guess some of the key learning things, what we learned is early identification and importance of facilitation of advanced care planning, where you talk about patients' wishes and goals and what they want to do, especially when it comes to the COVID situation, and how you can align our treatment planning according to their goals. And also it is important to facilitate the human connection, I guess, between the patients and families against all odds and difficulties in this complex situation. I guess because this is what the family is going to carry through, and that would help through their bereavement process. Thank you so much.
Thank you. Thank you, Dr. Kathiresan. Now we will move from Australia back to India, and like to welcome Dr. Rajan Sharma, and who will bring perspectives from Indian Medical Association. Dr. Rajan Sharma is a renowned orthopedic surgeon from Haryana, India. Dr. Rajan is National President of Indian Medical Association. He has published many research papers and is passionate about community service projects. Please welcome Dr. Rajan Sharma.
Good evening, everybody. First of all, warm greetings from IMA to all the members across various countries in the world. And as we discuss this scenario of COVID, I would just like to make a brief note about IMA. Indian Medical Association, as you all know or might be knowing, is one of the largest organization of doctors of modern medicine across the world, with around 3.5 lakh members, and which has its branches of pan India with 1,745 branches. As I was going through the discussions and was really enlightened. Now I am an orthopedic surgeon, but now due to my involvement in IMA, I have got quite a good view of COVID-19. But in this entire thing, we also must understand the healthcare delivery system, which has not seen much of investment over the past few years. And the healthcare delivery has been provided by all the single couple and doctor-owned setups across the country, wherever any help could not reach. In whichever way possible, we improvised, we brought in new technology. And still, as we see a massive explosion of cases in metro cities and the healthcare facilities bursting out of its seams, keeping in mind the huge size of the population of the country, we have to work inclusively all across, in which, whether it is the bigger towns or the smaller towns, luckily it is restricting itself to metros, but now it is spreading across. And whatever impact it comes, like Professor Valeria was saying, that the oxygen therapy and all these things have to be delivered at every district and these levels, because what I see, the precious time in losing the time of golden triage, where you can actually intervene and manage. So that has to come from below to top, and to decongest these setups in the metro cities, and where every hospital has to work and every doctor has to work as a national and to service of the country. But yes, certain issues which concern need to be addressed, and every healthcare provider, including the policy planners, have to have an inclusive growth in the matter of crisis. Every opinion does matter. Indian Medical Association has been was the first one to respond to COVID with its COVID guidelines. We have come up with COVID guidelines for living with COVID also. And through various webinars across the world, we have been, and in India, we have been educating all our branches across the country and members on the latest in COVID management and how to participate best. We are already working full steam in almost all part of the country and doing our duty in informing about COVID patients and testings to the authorities, district authorities. And we are with the government and we are all working together for the betterment of our community. But yes, challenges are there. A lot of challenges are there, whether there is testing, whether newer treatments, whether any future of promises of vaccination, and which all of us have to be in it together. You sitting abroad in the best of facilities, sharing your advances. We in India with a huge population number, because I still feel that COVID is still the unknown virus. And we have to fight this battle together in India and across the world, keeping in interest of the ailing humanity. Thank you.
Thank you. Thank you. Thank you so much, Arun Bhai, and thank you so much, Rajan. We now move on to Dr. Nandkumar Jairam to introduce Dr. Rajesh Chawla for his talk on ventilation. Rajesh couldn't join us earlier because he was busy with the Honorable Health Minister in a discussion.
Thank you again, Anupam. I'm pleased to invite Dr. Rajesh Chawla, a Senior Consultant Respiratory and Critical Care Medicine Specialist at Indraprastha Apollo Hospitals in New Delhi. He is a past President of Indian Society of Critical Care and the National College of Chest Physicians. He is also the former Chancellor of the Indian College of Critical Care Medicine. Dr. Chawla, please.
Can you unmute yourself, Rajesh, please?
Hello, am I audible now?
Yeah, yes, you are. Please go ahead. Thank you.
Good evening, and thank you very much for nice introduction. So I'm going to talk about a subject which is ventilatory management, which fortunately is not required in more than 0.5 to 1% of the patients. You know, if you see the pulmonary disease course and along the timeline, there are three kinds of people. One is that hyperacute, where the person has a severe hypoxemia and breathlessness, which leads to immediate intubation. And then there is indolent or improving, moderate to severe hypoxemia, but only moderate work of breathing. And then there is a biphasic, where there is an initial indolent course, which is typically after 5 to 7 days by the acute deteriorations with hyperinflammatory response, worsening respiratory failure, with bilateral infiltrates and consolidations, and they are intubated. So these are the kind of people you encounter. Now, you know, before you intubate these patients, of course, majority of the people will require oxygen, which can be a nasal cannula, or it could be a Venturi mask or a reservoir mask. You know, the ventilatory management of any patients with respiratory failure involves the non-invasive ventilatory management and invasive ventilation. You know, CPAP, NIV, and HFNAC has been controversial right from the beginning because of the aerosol generations. But lately, we've come to realize that if you could avoid intubation and continue with this, the chances of survival are more. So CPAP, NIV, HFNAC, all can be used with, of course, the aerosol precautions. And one thing which I'm finding, and I think all across people are finding very useful, is awake prone positioning. I used to think the patient is very dyspneic and probably you can't prone, but you'll be surprised most of the people who are put on these non-invasive devices, you can easily prone. Most 70 to 80% of them can be easily, and always target non-vigorous breathing. You know, if a person is having a very high respiratory drive on CPAP, NIV, or HFNAC, he will induce a spontaneous breathing induced lung injury, and the chances of outcome are very bad. So you should target non-vigorous breathing. If there is a vigorous breathing which you can't control, then probably that person should be intubated. As for the indication for intubation is concerned, of course, the impending airway obstruction, sign of unsustainable work of breathing, person breathing at 14 respiratory distress, he can't sustain for a long time. Refractory hypoxemia, hypercapnia or acidemia, encephalopathy or inadequate airway protection. These are the common intubation criteria. Now, this disease hypoxemia in COVID has a vascular component and a alveolar component. It is not the only alveolar like you have in a typical ARDS. Gattinoni, from the data from Italy, he had classified into two phenotypes. One is a phenotype which he called the low, which had a low elastance or a high compliance. And this group of patients had a low VQ ratio, low lung weight, and low recruitability. These patients can be ventilated with 6 to 8 ml, the respiratory rate about 18 to 20. They do not respond to recruitment maneuver and PEEP, about 8 to 10 of PEEP, and you target the PEEP plateau pressure less than 28 or 30, and driving pressure, which is the difference between PEEP plat and PEEP, about less than or equal to 15. And the other type, which is the phenotype H, which has a high elastance or a low compliance, which is classical ARDS, which we have been defining for last many years, and where you have to give a low tidal volume strategy. This group of patients have a low VQ ratio, low lung weight, and high recruitability. So you have to give 4 to 6 ml per kg. Respiratory rate, you can go up to 35 to overcome the hypercapnia. PEEP, these are the patients where you can give a higher PEEP. And these patients, when the PF ratio is less than 150, they respond very well to proning. And again, you target the P plat below 30 and the driving pressure equal to or below the 15 centimeter. Now, as far as the weaning of this patient is concerned, one thing which I want to stress is these patients require a long ventilation. If they survive, most of these patients would require 2 to 4 weeks. Average days of ventilation is about 14 to 16 days. Be patient in weaning. If you try to extubate these patients and re-intubate, the outcome of these patients is bad. Make transitions cautiously. Avoid abrupt changes in ventilation. Spontaneous breathing trials should be done only at the very end of the weaning process, not like every day we try in a normal patients. If tracheostomy is required, surgical tracheostomy is preferred because of less aerosols. And laryngeal and tracheal edema is known in this disease. So when you extubate, you need to be careful about these. So this is in a nutshell, in a summary, I've told about the ventilatory strategies in COVID-19. Thank you very much.
Thank you. Thank you so much, Rajesh. That was very helpful. And thank you so much, Dr. Nandkumar. We've learned a lot. I'm just going to summarize in 60 seconds before we go to a Q&A. In terms of clinical presentations, highly variable, deterioration can happen rapidly. We need to have a low threshold in terms of making a diagnosis. HCQ prophylaxis, some data from India shows promise. Treatment, can't say just now, more data needed. Plasma, safe, promising, more data needed. Remdesivir, some questions about safety, definitely has been shown to show faster recovery. In India, it's part of the Solidarity trial. Lipo-Rito, more data, wait for Solidarity. Anticoagulation, effective, and you have raised D-dimers, keep an open mind. Tocilizumab shows promise, trials underway. There's a question on Indian trials. Indian trials start next week. Steroids, some promise, when used early, some more data needed. Ivermectin, Nitazox, NAC, doxycycline, Etotimod, interesting, need data, need trials. Transfusion, no. Plasmapheresis, promise. Our trials are on. HBO might be interesting. Let's see what the Israeli study shows later on in the week. We had a nice talk on ventilation. We learned what Australia's done. We got an overview of how India has looked at the strategy. And of course, we got to understand from Randeep some of the challenges. And of course, Rajan talked about what IM has done. Now we move on to our Q&A. And we have precisely 15 minutes for the Q&A, because after that we need 2 minutes to log into a Sadhguru session that he has going with us. And to do the Q&A, we have two distinguished colleagues from the US, Dr. Anupama, who's a pediatric anesthesiologist at San Antonio. She's currently the Vice President of API and will become the President in 21. And Dr. Sanku Rao, an eminent gastroenterologist, one of the founders of GAPIO, former President of GAPIO, former President of API. So over to Anupama and Sanku for the next 15 minutes. And of course, please join us on the 30th when we have our next, on the 20th when we have our next session on women's issues, and we've looked at all the suggestions that have come out from Brahma and others. We will be doing specialty focused sessions, and there will come a time when we'll have to revisit some of the medication when we have more data in 6 weeks. So over to Anupama and Sanku.
Thank you, Anupam. And is Dr. Senkurao on this chat box somewhere? Dr. Senkurao? Okay,
Can you hear me now?
We can see you.
Go ahead.
Thanks, Anupam. So we will be both doing the Q&A session one after the other. There was a great speakers all across so many countries. So because of the shortness of time, I think we have to make the best use of the time. So the first set of questions is for Dr. Chawla. So I'm going to give all the questions in a row so we won't waste any time. First one is HCQ. Can it be taken as prophylaxis by the healthcare workers? If so, for how long? Keeping in mind the UK study did not show any beneficial. Number two, can you give guidance in the role of lopinavir and ritonavir? Number three, what is the role of Indomethacin and Nsaids in a COVID situation? Number four, is there any rational cocktail for non-complicated COVID patients? Dr. Chawla.
IPS, you have like 10 seconds to answer each question. Like this is like KB.
Is Dr. Chawla online?
Yeah, let me just unmute myself first. Thank you. So for hydroxychloroquine prophylaxis, I'm sorry, the data that we heard today, the data is not very clear. Again, more data to come. On Calitra, the combination, the lopinavir-ritonavir combination, New England Journal had an article about it. I actually posted it in the chat box. If you're really paying attention to the chat box, I posted a link to the New England Journal article. There may be some more data coming in later, I don't know, but the data very early was very disappointing. Indomethacin Nsaids. At one time, we were told not to use it. That causes ACE2. Nobody today spoke about the angiotensin converting enzyme inhibitor problems, the receptors. But ACE2s are a problem. That's what we thought originally. The Nsaids were not to be used. So we didn't really use Nsaids much. So I'm sorry, I don't have any data, anything to say about indomethacin specifically. And the cocktail, the mantra that I used was hit it early, hit it hard, hit it with all you got. So with all I got was remdesivir, I had tocilizumab, and I had plasma. I did try anakinra, that is an IL-1 blocker on a couple of patients. It wasn't very effective, lots of opportunistic infections. And also on hydroxychloroquine use, in our institutions, we did start off by using hydroxychloroquine. However, very soon we had a lot of problems, a lot of complications, QT prolongations. We were doing daily EKGs on these patients. And remember, in those days, we were not exposing a lot of our members to the clinical members. If a tech has to go to do an EKG, that tech is being exposed to COVID. We wanted to minimize that. So that's my brief thoughts on this.
Thank you, Dr. Chawla. The next set of questions is for Dr. Madhavi Gurusu on plasma treatment. Number one, are there any guidelines for plasma therapy? Number two, do we have to do blood grouping before the plasma infusion? Number three, what is the quantity to be given? Dr. Gurusu.
Thank you. So the guidelines of the plasma infusions, I can post it on the chat box, the standard websites. It is covidplasma.org, or any Mayo Clinic website has that. So that is regarding the protocol part. And of course, each hospital has their own individual protocols, but I think there is some kind of uniformity because this is nationally, at least in USA, and I'm sure in India that is the ICMR guidelines, but each institution should follow whichever clinical protocol that you're following, because remember, at least in USA, it is not yet FDA approved, and it has to be part of the clinical trial. The other part, what I got from the blood typing, yes, of course, please do. Just remember, it is not as the blood type, it is kind of the opposite when you look at the plasma, meaning that to simplify it, if it is a blood group O, you would have said it's he or she is a universal donor, whereas in the case of plasma, if it is AB, then you call it as a universal donor of the plasma. But kind of if you go, it is the opposite way but yes, you need the blood typing.
Thank you very much. The next set of questions is for Dr. Nambi, infectious disease. Number one, if we do enoxaparin at the higher dose of 60 BID, does it cause harm in conjunction against 40 BID? Number two, what is the role of steroids? Number three, role of Virovaxin. Number four, BCG, does it give any help in the immunity of these patients with COVID? Dr. Nambi. Go ahead, sir.
Dr. Nambi, are you there? Go ahead with the other set, Dr. Sankura Garu.
Okay. The one question is, it is a general question. One is that Dr. Chawla can answer, or I can do that quickly. What is the smallest period when symptoms get obvious, and the shortest period, I think, is about 2 days? And does the P95 give absolute protection? And I think the answer will be no. It depends on a lot of how it is worn, how old, is there a shield, is there a headgear, etc. So those that we can get over with. Dr. Chakravarti, one question, hypoxia in COVID patient, is it from the alveolar level or the molecular level of the hemoglobin?
Unmute yourself, Dr. Chakravarti.
Yes. Is it at the molecular level or is it at the alveolar level? It's a very good question. I'm not sure we know very well to answer that. Certainly, it is an ARDS process. So with being an ARDS process, it will be a lack of transmission of or diffusion of oxygen. So it must be at alveolar level from basic physiology. But I don't know if we have any other data beyond that. What we know is what we've heard earlier about the fact that patients come in with significantly low blood oxygen levels and actually don't feel as hypoxic or as distressed as they would normally feel in any other situation, which was a very surprising thing. We've seen people walk in with 65% SATs and really not being extremely breathless. And that really surprised us. But I think it's mainly an ARDS process.
Thank you very much. And Dr. Babu Ibrahim from UK, CRP level, how does it correlate with IL-6? In other words, does CRP correlate with the immune cytokine storm as a marker?
Okay. Both CRP is a marker of inflammation. It's non-specific. So it will go up, but in the patients I've seen, there is no correlation. Usually they both go up, but I have a couple of patients who are showing signs of cytokine storm, but the CRP is not high, IL-6 is high. So yes, theoretically both should go up, but medicine is medicine. Coronavirus doesn't read Harrison's, so it's not always the same.
Oh, Thank you very much. Now, thanks for the opportunity. Now I'm going to pass it on to Dr. Anupama Godemukula. Over.
Thank you, Dr. Senkurao. And everyone take a deep breath. A lot of speakers, and I think we all enjoyed listening to every speaker, excellent speakers. Thanks for being on the panel today. And the next question, my question, I'm an anesthesiologist, so I'm going to pose this question to Dr. Rajesh Chawla. Tips to decrease barotrauma and pneumothorax on the patients who are on the vent.
You know, the basic principles remains the same. You know, these patients, when they are not paralyzed, you should not allow a very high respiratory drive. You should make sure they do not have a high tidal volume. You know, sometimes these patients, when they are they are in the weaning process and you put them on a pressure support, they would create something like a liter with a very low pressure support. And the most important thing, the basic principle which we've been following for ventilating any ARDS patient is keep the P-plat below 28 or the lowest possible and the driving pressure below or equal to 50. These are the two very important things. And if you follow this, the barotrauma would of course be much less.
Thank you, Dr. Chawla. And my next question is to Dr. Madhvi Gursu. What is the indication of criteria for repeat plasma therapy? What should be the gap between the first and the second repeat plasma therapy? Anything you can share with us?
I don't think there is any kind of universal set guidelines. It depends on the clinical response or lack of, so to speak, of the patients. So in varied studies and even in our own institution, I don't think anything more than 2 infusions are made. I think that's a fair statement. And a repetition of the second infusion, give or take in like 2 to 3 days. But after 2 days, after 2 doses, I mean to say, is there any more efficacy of giving more? I doubt it.
Thank you, Madhvi. I don't think we have any pediatricians, but maybe one of you can answer, or maybe I'll ask Dr. Chhabra. What is the status of various intervention and drugs discussed in children? Children are having more, we see more and more in children now. So Dr. Chhabra, you're from New York. Maybe you can share some light on it.
So I'm an adult physician. I don't really have that much experience with pediatricians. However, our institution does have a very major children's hospital attached to us, and we were seeing a lot of children. The intensity of the illness was not that bad in children. However, what did surprise a lot of us was the Kawasaki-like syndrome that was seen post COVID. So there was a slide presentation that I saw that the patients who got these diseases, they got the illness, PMIS as it was called, post to something immune syndrome. The syndrome showed itself 2 to 4 weeks after the acute presentation of COVID. Now, in general, children were not that badly affected. The cytokine storm was not that badly seen. And one of the theories that I heard was because the level of the ACE2 receptors in those kids' lungs have not been as developed as in adults. And maybe that's why the children were not that sick. But PMIS is still, yeah, thank you for somebody, for Dr. Harsha Lakshmi, for putting it on the chat box. PMIS is a real disease which we have to watch out for.
Thank you, Dr. Chhabra. And the next question is to Dr. Sanjay Agarwal. So a patient has completely damaged lungs, and are they good candidates for lung transplant? You're a pulmonology critical care physician, so.
I don't have much experience in lung transplant patient-wise. If there is a lot of thought process on COVID about that, this being systemic disease, other organ systems are also affected, and there's a significant amount of clotting disorder as well. So I don't know if lung transplant is an option. There are some case reports where people have been accepted for lung transplant in major centers, but I don't know the outcomes of those. Time will tell.
Anupama, we will have to wind up in about 60 seconds because we need to log into Sadhguru's presentation. So maybe 2 quick questions.
The last question is to 3 speakers from India, US, and UK. So this is about the second surge. So I want to hear from 3 speakers from Australia, India, and so go ahead, one of you. Second surge, where are we?
Shall I take 10 seconds to answer that?
Yes.
So we are afraid in the medical community in the UK, we are not happy with our government. We are a little bit afraid of the fact that everybody is going back to their normal business, and we are expecting within 2 weeks from now that there will be a rise. So all hospitals are on a super preparation for this. So by the end of July, we expect a second surge.
Dr. Jayanti, what do you all think in Australia? Unmute yourself, Dr. Jayanti.
Yeah, I have. Sorry, our restrictions have been relaxed only in various stages. So where the government is very particular and meticulous. Having said that, with the latest protests and things, there is a fear that there could be a possible second surge sooner rather than later.
Any speaker from UK? Please share your thoughts.
Indranil did. In India, we are seeing a surge, so there's no question of a second wave. We don't know when the first wave is going to end. Randeep, would you like to comment on that? Because you have more knowledge than any of us. Randeep, would you want to comment on that second surge?
I would like to say that basically currently we are still having an ongoing surge of cases, and with the lockdown becoming less in 2 days' time from Monday onwards, there will be a huge surge of cases. My concern is that currently the surge is actually predominantly in large cities, maybe just about 12 cities or so, and majority of India doesn't have that many cases. But with this movement and with migrant populations going back to rural India, we may see increasing number of cases in rural India, which is going to be a problem.
Thank you, Anupam. Over to you.
Thank you so much, Anupama and Sanku. Thanks ever so much to everyone from joining from across the world. We had Mongolia, New Zealand, Australia,